today's RRR YouTube series on the topic diagnostic accuracy that includes sensitivity, specificity, positive and negative predictive value and the likelihood ratios. Myself, Dr. Avinash SS, mentor at Study Medic Study MRCOG Group in the area of biostatistics and health research methodology. Today, we will discuss how to make these contingency tables and how to calculate the diagnostic indicators. Now, how do we diagnose? We use a diagnostic test. What can be a diagnostic test? The diagnostic test can be the history of symptoms or by examination of the signs, or we can diagnose by interpretation of the investigations. All this can be considered as a diagnostic test. Now, what is a diagnostic accuracy means? Diagnostic accuracy means ability of a test to detect or rule out a disease or a condition without missing many correctly. Whereas it is also the ability of a diagnostic test to distinguish between the presence or absence of the disease. Now, which are the statistical indicators of a diagnostic accuracy study? It is sensitivity, specificity, positive predictive value, negative predictive value, likelihood ratio, positive as well as negative, area under curve, and diagnostic odds ratio. All these are indicators. Now, what is an index test versus reference test? Index test is the test that is being studied. What it is? It is the test that is being studied. Against the reference test is the benchmark or the gold standard test that is used for comparison. The gold standard test is the best available diagnostic method and it is assumed to be highly accurate. For example, if the index test is a tumor marker, then the reference test would be histopathology of the biopsy taken from the specimen or the area. This is the difference between index test and the reference test. Now, how do we form a contingency table? Now, the contingency table we form by, if this is the index test and this is the gold standard test, then if the index test is also positive and gold standard test is also positive, then it is called as true positive. Then if index test is also negative, gold standard test is also negative, then we call it as true negative. Similarly, if the index test is positive and gold standard test is negative, then it is called as false positive. If the index test is negative but the gold standard test is positive, then it is called as the false negative. This is the 2 by 2 contingency table. Here in this column we represent true positive plus false negative, total amount of the people who are having the condition, and in this column we represent true negative plus false positive, total number of the people who are not having the condition. Whereas in this row we represent those who have tested positive, that is true positive plus false positive, and in this row we represent those who are tested negative, that is true negative plus false negative. Here we actually get what is called as the total number of the people or the patients or subjects. This is the how we write the 2 by 2 table. Now, once we write the 2 by 2 table, we will now understand the diagnostic indicators. So what is sensitivity? What is sensitivity? So the sensitivity means amongst those who are amongst those who are having the condition, amongst those who are having the condition, how many are tested positive? See the up to down arrow. See the up to down arrow. That means sensitivity is the true positive divided by true positive plus false negative. It is also called as true positive rate. Then what is specificity? What is specificity? Specificity is amongst those, look at the down to up arrow. Amongst those who are not having the disease or the condition, how many are tested negative? So specificity is true negative divided by true negative plus false positive. It is also called as true negative rate. Now what is positive predictive value? Look at the left to right arrow. Amongst those who are tested positive, how many are having the condition? Amongst those who are tested positive, how many are having the condition? So positive predictive value is true positive by true positive plus false positive. Then what is similarly the negative predictive value? Negative predictive value is, look at the right to left arrow. Amongst those who are tested negative, how many are not having the condition? That is, negative predictive value is equal to true negative by true negative plus false negative. Here true negative plus false negative means those who are tested negative, all total. Now what is positive likelihood ratio? What is the positive likelihood ratio? It is used if you want to evaluate how much a diagnostic test result will change the probability of a disease. So before a disease, what is that probability, and after this disease, how much this diagnostic test result will change the probability of that disease being present. That is called as positive likelihood ratio. Here you write sensitivity and specificity, but instead you do 1 minus specificity. Means sensitivity is nothing but true positive rate, specificity is true negative rate. 1 minus true negative rate is nothing but false positive rate. So likelihood ratio plus is true positive rate divided by, or true positive rate by false positive rate. So that is called as the positive likelihood ratio. So if the positive likelihood ratio is more than 10, then the test probability that there is a disease strongly increases. That means it will test amongst those who are having the disease, how many are tested positive compared to amongst those who are not having the disease, how many are tested positive. So if it is more than 10, it strongly increases the likelihood of the disease. If it is near to 1, it is not of any diagnostic value. Higher the likelihood ratio, better it is the test to rule in the disease. So this is positive likelihood ratio. Similarly, what is negative likelihood ratio? Here, he will evaluate how much a diagnostic test will change the probability of the disease when it is negatively reported. That means here once you write sensitivity by specificity, here instead you do 1 minus specific sensitivity. So what is sensitivity? It is true positive rate. What is specificity? It is true negative rate. So instead here what we have to do is, pardon me, here you write 1 minus true positive rate divided by the true negative rate. So what is true positive rate? It is sensitivity. So 1 minus true positive rate becomes false negative rate. Okay, 1 minus true positive rate becomes false negative rate. So above will be false negative rate divided by true negative rate. So likelihood ratio negative is false negative rate divided by true negative rate. That means amongst those who are having the disease are tested negative compared to who are not having the disease are tested negative. That is called as the negative likelihood ratio. Now negative likelihood ratio is said to be of very good value, diagnostically accurate, if it is less than 0.1. It strongly decreases the likelihood of the disease. Whereas you can see positive likelihood ratio, if it is more than 10, it strongly increases the likelihood of the disease. And similarly, likelihood ratio is near to 1, no diagnostic value. Lower is the negative likelihood ratio, better that is the test to rule out the disease. Whereas higher is the positive likelihood ratio, better it is the test to rule in the disease. This is the difference between positive and negative likelihood ratios. So you note down that the negative likelihood ratio, this is the negative likelihood ratio, is nothing but false negative rate divided by true negative rate. That is 1 minus sensitivity divided by specificity. So again, here you note it down. Now what is diagnostic odds ratio? Now what is diagnostic odds ratio? Now you can see here the diagnostic odds ratio it is the odds of a positive test result in patients with the disease. That means what is the odds of the positive test results in patients with the disease? That is odds of positive test result would be, that is equal to true positive by false negative, the odds in those with the disease. So this is the people with the disease. The odds that test is positive is true positive by false negative, and divided by, it is divided by the odds of positive test result in patients without the disease. That means who are having not having the disease. These are the people not having the disease, and the odds would be that odds of a positive test results in those not having the disease is false positive by true negative. So when we do that, what do we get? It is nothing but likelihood ratio positive divided by likelihood ratio negative, or it can be calculated as odds of having a positive test in with disease, true positive by false negative, divided by odds of having positive test in those without not having the disease, false positive by true negative. This is diagnostic odds ratio. Now diagnostic odds ratio of 1, it indicates the test does not discriminate between the disease and absence of the disease. Now higher the diagnostic odds ratio, better it is a discriminatory test. A diagnostic odds ratio of more than 20 means it is a very good discriminatory test. If the diagnostic odds ratio is less than 1 means this test performs worse than the chance. So that is diagnostic odds ratio. It usually measures the overall test effectiveness. Now, what is prevalence? So prevalence is nothing but pre-test probability. It is nothing but pre-test probability. That means we know those with having the disease or condition, total number of disease divided by total number with and without the disease, all the people. That means those with the condition is true positive plus false negative. So this is those with the condition, true positive plus false negative, and those all together. So everyone together. That is the prevalence. It is also called as pretest probability. Now, what is the effect of prevalence on positive predictive value, negative predictive value, as well as the other sensitivity and specificity? Okay, you can see here as the positive predictive, as the population prevalence increases, the positive predictive value will increase. As the prevalence of a disease increases, the negative predictive value of the disease test decreases. Whereas sensitivity and specificity are inherent characteristics of the test, it will not change with the prevalence of the population. For example, a Mantoux test that is having a very poor positive predictive value, if the prevalence of tuberculosis, let us say, is less in developed countries, the same Mantoux test will have less positive predictive value, whereas in developing countries, the Mantoux test will have higher positive predictive value because the prevalence of tuberculosis is high. So this is the effect of prevalence on positive predictive value and negative predictive value. Now, how to rule in or rule out a disease? Now you can see here, this is the double bump chart, which will represent what is the cutoff value for a diagnostic test above which or below which you can rule in or rule out the disease. If such a test is 100% sensitive, that means it is a highly sensitive test and it gives a negative result, that means all are true negative. So it is best to rule out a disease. For a highly sensitive test, when it gives negative, it is best to rule out a disease. So it is SNOUT, sensitive test, negative, rule out disease. Similarly, if a highly specific test is useful when it is giving positive, that means you can definitely rule in the disease. This is this snout and spin mnemonic used to see the diagnostic utility of a highly sensitive and specific test. A highly sensitive diagnostic test, a qualitative test, is useful when it is negative to rule out. A highly specific qualitative diagnostic test is useful when it is positive to rule in the disease. Now let us see the case scenario and try to solve the problem. Here a 28-year-old primigravida presents at 32 weeks of gestation with persistent headache, high blood pressure and mild pedal edema. The doctor suspecting preeclampsia and decides to perform a diagnostic test. The diagnostic tests that is being considered are the 24-hour urine protein estimation, which is actually a gold standard for confirming significant proteinuria, which is so often seen in preeclampsia. Now let us consider this as reference test. Whereas let us compare the urine dipstick test that is done for protein, which is a very quick, easily performable bedside test for proteinuria, as an index test. If out of 100 women that is tested, if out of 100 women that is tested, we are writing it 100 is a total, 40 excuse me, truly have significant proteinuria. That means 40 of them are having the condition. 35 of these who are having the significant proteinuria are also tested positive by dipstick. So 35 of this are also tested positive by dipstick. That means it is a true positive finding. Now 50 of the remaining 60, so remaining are 60, 40 plus 60 is 100. 50 of the remaining 60 are tested negative. That means they are true negative. Now we have filled the numbers in the 2 by 2 table. We'll see we can fill the rest. So the rest 5 is false negative and the rest 10 is false positive. So 45 will be tested positive and by the index test dipstick, and 55 will be tested negative by the dipstick. Now we have filled the table. Now let us calculate the one by one. So what is sensitivity? Sensitivity is those who are having the condition tested positive, that is true positive by true positive plus false negative. So 35 by 40. So 35 divided by 40, that is 87.5%. Okay. So that is the up to down arrow. Now what is specificity? Down to up arrow. Amongst those who are tested negative, how many are amongst those who are not having the condition, how many are tested negative? True negative by true negative plus false positive. So it is 50 by 60, which is equal to 83.3%. Now what is positive predictive value of the dipstick test? Positive predictive value. So left to right value, right arrow. Amongst those who are tested positive, how many are having the condition? So it is true positive plus divided by true positive plus false positive. So it is 35 by total 45. That is equal to 77.8% is the positive predictive value of the dipstick test. What is the negative predictive value of this dipstick test, which is true negative by true negative plus false negative? That means amongst those who are tested negative, how many are truly amongst those not having the disease? So 50 divided by 55 is 90.9%. So this is a negative predictive value. Now let us see the positive likelihood ratio. So positive likelihood ratio is sensitivity divided by 1 minus specificity, or true positive rate by false positive rate. So sensitivity is 35 by 35 by 40, okay, divided by 1 minus specificity. So 1 minus specificity is 50 by 60. So all together when we solve, we get the likelihood ratio of 5.24. Not a great diagnostically accurate test, but okay. If it is more than 10 likelihood ratio, it would have been a very good discriminatory test. Now what is negative likelihood ratio? Negative likelihood ratio is 1 minus sensitivity by specificity, that is false negative rate by true negative rate. So 1 minus sensitivity is 1 minus 35 by 40 divided by specificity is 50 by 60. When we solve, it gets around 0.15. So it is again not a very great discriminatory test, even when it is negative, because it should be less than 0.1 to be very good discriminatory test. Negative likelihood ratio should be less than 0.1 to be very good discriminatory test. Now coming to diagnostic odds ratio. So it is the ratio of likelihood ratio positive by negative. So or true positive by false negative divided by true negative by false positive, all are same. When we calculate, it gives us 35. What is the meaning? The odds of a positive test result in a woman with preeclampsia are 35 times higher than in a woman without preeclampsia. Okay. So that odds 35 times it is more of a positive test in those with preeclampsia compared to those without preeclampsia. That is the meaning of diagnostic odds ratio. Overall accuracy it will give. Now, what is the prevalence of proteinuria here? Prevalence is those with the disease, that is around 40 divided by 100. So 40% is the prevalence. Now there is one more what is called as diagnostic accuracy, which is equal to, it is a diagnostic accuracy indicator, true positive plus true negative, that is those who are truly positive and truly negative compared to the total, and it comes to around 35 true positive, 50 true negative compared to total. So around 85% is the diagnostic accuracy overall. So this is the solved 2 by 2 table of sensitivity, specificity, positive and negative likelihood ratio, diagnostic accuracy, and diagnostic odds ratio, and negative and positive predictive value. You can pause and see here to understand all the formulas and how it is calculated before moving further. Now, how to calculate positive predictive value when we give sensitivity and specificity and prevalence. We can use the Bayes theorem to calculate that. So what is the formula? The formula that says is sensitivity into prevalence divided by sensitivity into prevalence plus 1 minus specificity into 1 minus prevalence. This follows the Bayes theorem. When we solve it, it is sensitivity is true positive divided by true positive plus false negative. Prevalence is true positive plus false negative divided by all total. So this will cancel. True positive plus false negative will cancel. It will become true positive by total. Similarly, sensitivity into prevalence, when we do same, you will get true positive by total. But when we do 1 minus specificity, it is nothing but false positive rate. It is nothing but false positive rate, which is false positive by true negative plus false positive. And 1 minus prevalence is, instead of true negative plus false negative, we take true negative plus false positive divided by everyone. So this and this will cancel and it will become false positive by total. So overall it will give true positive by true positive plus false positive, which is nothing but positive predictive value. Similarly, we can use either of this formula to calculate. Similarly, negative predictive value, the formula used is specificity into 1 minus prevalence divided by specificity into 1 minus prevalence plus 1 minus sensitivity into prevalence. So when we solve this in Bayes theorem, specificity is true negative rate, that is true negative by true negative plus false positive. 1 minus prevalence is true negative plus false positive by total. So this and this will cancel. It will give true negative by total. Similarly, specificity is true negative by true negative plus false positive. Same, it will become true negative by total. Then when we solve 1 minus sensitivity, it is nothing but false negative rate. False negative by true positive plus false negative. And prevalence. Prevalence is again true positive plus false positive by total. So this and this will cancel. It will give false negative by total, which will give us true negative by true negative plus false negative, which is equal to negative predictive value. We can use either of these to solve the negative predictive value. You can pause here and listen again to understand the calculation based on Bayes theorem. Now we will see how to calculate the post-test probability. Now what is the post-test probability? We know that the post-test probability is nothing but, pre-test probability is nothing but prevalence. Now using pre-test probability, how do we calculate the post-test probability? We can use some nomograms. Okay, so what is this name of this nomogram used here is the Fagan's nomogram. If pre-test probability before doing the test was around 25% and The likelihood ratio of this test was around 0.4. Then what would be post-test probability? Around 11. So before conducting this test, the probability of the disease being present is, that is the prevalence is around 25%. But after this test, which has a likelihood ratio of 0.3, the post-test probability has become 11. So it has increased, it has decreased actually. Okay, the post-test probability has decreased. Why it has decreased? Because the likelihood ratio was less. Now, before it was 20% and the likelihood ratio was also 20%. Pre-test probability of prevalence of the disease was 25%. The likelihood ratio was 20. Then what will happen? You can extrapolate this and you can see that post-test probability will increase to 90% after conducting the test. So, what is the relationship between probability and the odds? So, probability is events divided by total. For example, odds will be events divided by the remaining. For example, the probability of heads in flipping a coin is 1 out of the total possibility is 2. Whereas the odds of a heads in a flipping coin is 1 and the remaining is tails 1. This is the difference between odds and probability. Now the relationship is probability is odds by 1 plus odds, whereas odds is probability by 1 minus probability. These concepts we can use. If sensitivity is 0.9, specificity is 0.8 and the prevalence is let us say 0.4, that is a 40%. What is the post-test odds? Now prevalence we know is nothing but pre-test probability, which is 40%. Pre-test odds is nothing but odds is pre-test probability divided by 1 minus pre-test probability. We discussed in the previous slide the relationship between odds and probabilities. Odds is equal to probability by 1 minus probability. So this is pre-test odds calculating from the prevalence. Pre-test probability by 1 minus pre-test prevalence, which is 0.4 by 0.6. 1 minus 0.4 is 0.6. It will come to around 0.66. That is 66% is the pre-test odds. Now what is the positive likelihood ratio? That is sensitivity by 1 minus specificity. That is 0.9 by specificity is 80%. 1 minus specificity is 20%, which is equal to 4.5 is the positive likelihood ratio. What is the negative likelihood ratio? 1 minus sensitivity by specificity, that is 1 minus 90%, that is 10% divided by 80% specificity, which is very less. 0.125 is the negative likelihood ratio. The good likelihood ratio, positive is more than 10. Good diagnostically accurate likelihood ratio, negative is actually less than 0.1. This is neither of it. Now, what is the post-test odds? Now we have determined pre-test odds. Now we determine post-test odds for a positive test. It is nothing but pre-test odds into likelihood ratio positive. So 0.66, 66% into 4.5. The post-test odds will be 3. Now what is the post-test odds probability for the positive test? From the odds we can calculate probability. What is the formula? For probability is post-test odds divided by 1 plus post-test odds. That is 3 divided by 1 plus 3, that is 3 by 4 is 75 is the post-test probability, 75%. So pre-test probability of a positive test was 40% earlier. Now it is after the test it has improved to 75%. Now what is the post-test odds for a negative test? It is pre-test odds for the negative test into likelihood ratio negative. That is 66 into 0.125, it is 0.08%. And post-test probability for negative test is post-test odds for negative test divided by 1 plus post-test odds. And we can extrapolate and calculate the answers. Now, what is the use of this post-test probability? Given this test result, what is the chance this patient really has a disease? Is what post-test probability will give. It guides us further course of action. That means if post-test probability of transvaginal ultrasonography in detecting ectopic positive is 90%, then we will likely admit and plan laparoscopy. Whereas if posterior probability of TV is ectopic negative, that means when it tests negative is 3.5%, which we found out now, then we can safely observe, repeat the beta HCG levels or follow up of the patient. So it will guides the further course of action, finding out the posterior probability of positive and negative test. It moves from pre-test probability, the clinical suspicion, to a posterior probability of updated risk. If post-test probability of pulmonary embolism is more than 85%, we all might think anticoagulation we can start without further testing. A test with high sensitivity and specificity may still yield low test probability, post-test probability in low prevalence population. This you have to remember. So we need not overuse the diagnostic test here. So this will prevent overdiagnosis and unnecessary treatment when the prevalence is low, even when the sensitive and specific test is specificity is good. These are the uses of post-test probability. Now, what is receiver operator characteristic curve? ROC curve is receiver operator characteristic curve. Now, this is always a graphical illustrate to plot sensitivity against 1 minus sensitivity. In other words, sensitivity is the true positive rate against 1 minus sensitivity is 1 minus true negative rate, which is the false positive rate. So when we plot true positive rate against false negative rate, false positive rate, that graph is called as receiver operating characteristic curve. How does it plot? It plots as at a particular cutoff value of a continuous test, for example, a tumor marker, beta HCG, or a new tumor marker, etc. If this at this particular cutoff value, this is the true positive rate and this is the true negative false positive rate. At this particular cutoff value, these are the true positive and false negative rates of a particular test. So let us say it is tumor marker 1. Let us say another tumor marker 2. Now when we compare, there is a line of indeterminate line which will tell it is 50-50. That means the area under the line will give the diagnostic accuracy, area under curve. If the area under curve is 50%, then the test is indeterminate. Now you can see the green line, it's a tumor marker 1, which is very closer to the true positive rate. Okay, it is a area under this particular tumor marker graph, ROC is very good, more than 0.8 it is. Okay. So the whole area we have to consider the whole area. Whereas similarly, when we consider the second tumor marker, you can see that area under this is little bit less. The area under this is little bit less. This area. So the which test is better? The tumor marker 1 is a very good diagnostically accurate test compared to tumor marker 2. Now where do we select the cutoff? We select the cutoff where there is highest true positive rate and lowest false positive rate. Suppose let us say here we can put the cutoff. So it is a trade-off between true positive rate and false positive rate. So for all this we can use the receiver operating characteristic. So it's a graphical tool. It's a graphical tool as I discussed, which is used to evaluate the diagnostic accuracy when test results are continuous, and it can compare the test accuracy between two tests, choose the best cutoff. If area under curve is 1, it is a perfect test, it is equal to 1. If it is 50%, it is no better than a chance, it's an indeterminate test. More than 0.9 is excellent test, 0.7 to 0.9 is moderate, less than 0.7 is a poor accuracy test. So I already told we can visualize trade-offs here. If high sensitivity is prepared, so that is when missing disease is dangerous, for example ectopic pregnancy, we prefer more true positive rate. Whereas high specificity is preferred when over treatment is harmful, that is example chemotherapy in a cancer. Then we choose very low specificity or high false positive rate, low false positive rate. So this is how we use the ROC curve to evaluate the diagnostic accuracy. So in today's RRR video, we studied the Diagnostic indicators, sensitivity, specificity, positive and negative predictive value, positive and negative likelihood ratio, diagnostic accuracy, diagnostic odds ratio, prevalence, how to find out positive and negative predictive value using sensitivity, specificity and prevalence, using Bayes theorem and other formulas, and what is the relationship of the ROC curve. I hope this was a very useful session. Thank you and all the best.